Hi guys, welcome to Radhika. So the question for today is a 30-year-old male presented with tense ascites, abdominal pain and hepatomegaly. On evaluation, he was found to have a hemoglobin of 8 grams, WBC of 2500 and platelet count of 90,000 and the bilirubin was 3 milligrams per deciliter which is increased. Urine hemosiderin is positive. A hematologist opinion was obtained and a flow cytometry was suggested. And the flow cytometry showed red cells which are deficient in CD55 and CD59. What could be your possible diagnosis? So let us summarize this and come to some conclusion. So the patient is having ascites, abdominal pain and hepatomegaly. So what does this indicate? You have some abdominal pathology. So you would have learned in your medicine and surgery. So this particular triad is seen in one condition. What is that condition? So whenever you have a patient with these three findings, you have to suspect one diagnosis. So here your diagnosis which you should suspect is the Budd-Chiari syndrome. So what is Budd-Chiari syndrome? It's due to thrombosis of your hepatic vein. Okay, it's due to thrombosis of your hepatic vein. So whenever your hepatic vein is thrombosed, you can have an abdominal pain. You have a very tense ascites and a hepatomegaly. So this is one finding. The patient is having thrombosis. So next, the patient is having anemia. Hemoglobin is low, WBC is low, platelet is low. So the patient is having pancytopenia, right? So that's the next thing. So what does the next lab investigations indicate? Your bilirubin is raised, your urine hemosiderin is positive. So what does that indicate? Your bilirubin is increased, your urine hemosiderin is positive, the patient is having anemia. So what is it connected? So whenever a patient is having anemia, you're doing a liver function test, your bilirubin is raised, your urine hemosiderin is positive. Why? Why should bilirubin get raised? It's all because of the hemolysis. So why your urine hemosiderin is positive? To further narrow down your diagnosis, you have another clue. Your urine hemosiderin is positive. That means it indicates the patient is having a intravascular hemolysis. Okay, so hemolysis can be intravascular or extravascular. So whenever your RBCs get lies inside the intravascular compartment, your hemoglobin will be released, which can be converted to hemosiderin, and that's why your hemosiderin is positive. So basically, the patient is having pancytopenia, thrombosis and hemolysis which is intravascular. So this question is a little bit easy because they have given you an important finding in a diagnostic test. Your flow cytometry showed red cells which are deficient in CD55 and CD59. So this is going to clinch your diagnosis. Okay. Now we'll just summarize this and go for the options. So it's basically a 30-year-old male who is having thrombosis of the hepatic veins, pancytopenia, intravascular hemolysis, and flow cytometry is it's a test which is done through a machine in which the cells flow. You can analyze any cells in suspension. So those cells, red cells, are deficient in CD55 and CD59. So now all these 4 points put together, you should be able to come to a diagnosis after looking at the options. Okay. So this is a characteristic triad: thrombosis, hemolysis and pancytopenia. It's seen in one condition. So which among these can cause that? So the patient is having thrombosis, the patient is having hemolysis which is intravascular, the patient is having pancytopenia and red cells which are deficient in CD55 and CD59. So the diagnosis here is paroxysmal nocturnal hemoglobinuria. So why PNH, why it occurs and what's the pathogenesis, all that I'll explain you. Okay, so what is PNH? PNH is paroxysmal nocturnal hemoglobinuria. So why have I put this complement here? So it has something to do with complement. Okay, so in paroxysmal nocturnal hemoglobinuria, the lysis of the red cells is because of your complement activation. Your complement gets activated. So you have to know a little bit about the complement pathway, then only you will understand the pathogenesis. Okay, so just in short, I'm not going to explain it in lengthy way. So remember, complements are nothing but proteins which are present. So you have different complements from complement 1 to complement 9, and it's like a double-edged sword. So whenever you have a infection or some other injury, there are certain conditions in which your complement needs to be activated, but excessive activation of complement is again dangerous, so it has to be put on check. Okay, like your coagulation cascade. Okay, so the complement should not be too excess or too less. It has to function normally whenever it is necessary. Whenever the function is over, it has to be put under control. Excessive complement activation is also dangerous. So you should know what all will activate the complement and what all will inhibit or regulate the complement. Okay, so any immune complex, your immunoglobulins, can activate your complement. Okay, your IgA and your immune complexes. So you have different classical, alternate and other pathways, so I'm not going to go into those details. So what I want you to understand from this PNH point of view and complement is, you have some complement from complement 1 to complement 9, and the end product you should know, it is called MAC, membrane attack complex, which is formed by C5b to C9. So to obtain this end product MAC, which is going to cause the lysis of a cell, you need so many enzymes and so many other complements from complement 1, 3, 4 and everything. Okay, so to obtain this MAC, you need so many enzymes like your C3 convertase and C5 convertase. So you no need to memorize this table as of now, just listen what I'm saying. Okay, so to form this MAC, you need all these C3 convertase and C5 convertase. So just think logically, if you want to inhibit this MAC, you can either inhibit your C5 convertase or your C3 convertase, so your MAC will not be formed. Okay, so in PNH, what happens is, you have mutation in a gene called PIGA gene. Okay, you have mutation in a gene called PIGA gene, which is called phosphatidyl inositol glycan A. Okay, so this gene is mutated. Because this gene is mutated, you don't have certain proteins, certain GPI linked proteins. So what is GPI linked proteins? Glycosyl phosphatidyl inositol linked proteins. So what are those proteins? CD55, CD59 and C8 binding protein. So what are these new numbers, CD55 and CD59, and what does these do with the complement? So these CD55, CD59 and C8 binding proteins are called complement regulatory proteins. They are going to keep the complement pathway under check. So whenever there is excess activation of complement, they are going to inhibit it. So how do they inhibit? So CD55 can inhibit your C3 convertase. It's otherwise called decay accelerating factor. Whereas your CD59, okay, so this will inhibit your MAC, okay. So it's called membrane inhibitor of reactive lysis. Likewise, your C8 complement binding protein, that is going to prevent activation of your complement pathway. So whenever you have deficiency of this complement regulatory proteins, there is no inhibition. So what happens? There is excessive activation of complement. So whenever there is excessive activation of complement, what happens? Your cells will get lysed. So because your RBCs are getting lysed, that's why you have hemoglobin urea. Okay, I'll just summarize it again. It will be little difficult to understand initially, so if you just watch it again, you will understand. Okay, so in PNH, you have mutation in PIGA gene, that's called phosphatidyl inositol glycan A gene, which is going to code for certain GPI linked complementary regulatory proteins. Okay, so what are those complement regulatory proteins? CD55, CD59 and C8 binding protein. Okay, so at this point what you need to remember is you have lots of complements from complement 1 to complement 9. So the end product is called MAC, membrane attack complex, and in between you have so many steps. Okay, so what is your problem in PNH is you don't have a check on this MAC. So this MAC gets formed happily. So you have excess of MAC being formed, which will attack your RBC membrane and causes hemolysis. So what should be your treatment part? You have to somehow inhibit MAC. How will you inhibit MAC? So MAC is formed by your activated complement 5 to complement 9. Your main problem in PNH is you have a lot of membrane attack complex which is causing lysis of RBC. So you have to inhibit this MAC. So you treat it by complement 5 inhibitors. You have drugs which can inhibit your complement 5, activation of complement 5, that is called eculizumab. Okay, so eculizumab is a drug which is used in the treatment of PNH, which can inhibit the activation of complement 5. So I hope you all understood little bit about PNH. I hope it's clear. So it's basically due to defect in proteins which regulate the complement. Because there is deficiency of the proteins which regulate complement, you have increased activity of membrane attack complex, which is going to cause lysis of your red cells. So the treatment part is you have to inhibit this, so you give eculizumab. So if you remember, I told in the beginning, you should not be happy by giving a drug and inhibiting MAC. Everything comes with a cost. Okay, when you're going to inhibit the complement, let us imagine the patient is having some infection. So whenever you have infection, your body have to fight and kill those cells which are infected or the infective organism. For that you need MAC. So if you have an infection and you don't have a MAC form, you're more prone for infection, especially certain infections. Okay, so you're giving this eculizumab happily to the patient with PNH. The patient will not form MAC, but at the risk of certain infection. So the patients, when treated with eculizumab, they are more prone to get infected by Neisseria, meningococcal infections. Okay, Neisseria and toxoplasmosis. Okay, so meningococcal infections can occur in this patient who are treated with eculizumab because you are inhibiting your MAC. So PNH is a very interesting disease if you understand the complement pathway. It's the only disease which is only RBC disease which is due to an acquired genetic defect. Okay, all your hereditary spherocytosis and all those are due to hereditary conditions, whereas PNH is due to a acquired genetic mutation. And another interesting thing is it's called paroxysmal and nocturnal. So it will be an intermittent hemoglobinuria. And why is it nocturnal? When you sleep, the pH of the blood will be reduced. So whenever your pH of your blood is reduced, your complement system can get activated. That's why it is nocturnal. So this is about the PNH. Okay. And in PNH, your RBCs will not have CD55 or CD59. And how you're going to diagnose it? Not by doing a CBC or your urine hemosiderin. You have to confirm that it is PNH. Okay. So what can you do for screening? What can you do for confirmation? That's also important. Okay. So for screening, you have something called your sucrose lysis test. Okay, so I'm not going to go into much details of those tests. You have something called sucrose lysis test. So whenever you add sucrose and serum which has complement, so the patients with PNH, they are more prone for hemolysis. You have to measure the amount of hemolysis happening. So sucrose hemolysis test can be used, and you have another test that's not a screening test, but you have something called HAMS test. So all these tests can be used for screening of PNH. But what is going to be your confirmatory test? So you have to go for flow cytometry, in which you have your red cells which is deficient in CD55 and CD59. And this flow cytometry test, we call it as FLAR, fluorescent arrow lysine test. It's called fluorescent arrow lysine test. Okay. So this is about paroxysmal nocturnal hemoglobinuria. So I'll just summarize all the findings which I've told so far. So PNH is it's an acquired defect in the RBC. So that's why you get PNH. So what is that acquired defect? It's a mutation in the PIGA gene. So because of this mutation, you have deficiency of GPI linked complementary regulatory proteins. So what are those complementary regulatory proteins which are deficient? CD55, CD59 and complement 8 binding protein. So because you have deficiency of these complement regulatory proteins, there is unchecked activation of your complement which cause lysis of your red blood cells, which is intravascular. Okay, and the patients with PNH can have hemolysis, thrombosis and pancytopenia. They can have pancytopenia. So whenever you see this triad, you have to think about PNH. Okay, and this thrombosis can occur in the cerebral veins also, but it can occur in hepatic veins when we call it as a Budd-Chiari syndrome. Okay, and the treatment is you have to inhibit MAC. So you give eculizumab to the patient, but when you're going to treat with this drug, it's a iatrogenic complication. You're inhibiting the late complement pathway, so the patients are more prone for meningococcal infections by Neisseria as well as sometimes by toxoplasmosis also. Okay, and the screening test is your sucrose hemolysis test, and you can do a HAMS test, which is acidified serum test, but your confirmatory test is flow cytometry, which we call it FLAR, fluorescent aerolysine, where you have red cells deficient in CD55 and CD59. So I put up a video on flow cytometry. You can watch that to understand about flow cytometry. And this is about your PNH. And I told you why it's paroxysmal and nocturnal. Okay. So I hope now you're clear with this concept of paroxysmal nocturnal hemoglobinuria. So remember the triad: thrombosis, hemolysis and pancytopenia. And PNH can precede the development of aplastic anemia also. So the answer is PNH. Thank you.